Assisting in Pulmonary Medicine Part 2 lecture. The following will be covered in the PowerPoint slides. Chronic obstructive pulmonary disease is a group of diseases with common characteristics of chronic airway obstruction. In this classification, we have chronic bronchitis, bronchiectasis, asthma, pneumoconlosis, and emphysema, most commonly due to smoking. Asthma is an inflammation and bronchospasms with resultant airflow obstruction and may be chronic. Non-productive coughs, dyspnea, expiratory wheezing, chest tightness, and difficulty breathing are all symptoms that can occur. It is important to teach patients to perform peak flow measurements to assess airflow. During an asthma attack, medical intervention may be required, such as rescue inhalers. Anti-inflammatory medications and nebulizers also can be used in these instances. Patient education for meter dose inhalers. Instruct the patient in the use of a meter dose inhaler as follows. It's important to shake the canister vigorously and place it into the mouthpiece device. Open mouth and hold canister approximately 1 inch away. Exhale normally, then while beginning to inhale, slowly depress the canister, releasing the meter dose medication. The patient's lips should be over the opening of the canister during this part. Continue to breathe in until your lungs are full. Hold the breath to a count of 10 and breathe out normally. If a second dose has been prescribed, wait at least 1 minute in between puffs. Pneumoconlosis. Most of these respiratory diseases are occupational and consequences of long-term exposure to unsafe air in workplaces. Coal mining, insulation manufacturing, shipbuilding with asbestos, and stone cutting and sandblasting are all hazards. Common symptoms are dyspnea, cough, and emphysema-like changes, and increased risk of lung cancer. Emphysema is a progressive obstructive disease in the pulmonary system that is irreversible. Loss of elasticity in the walls of the alveoli eventually stretch these walls and then they break, enabling them to exchange the oxygen and carbon dioxide in the body. Cigarette smoking is a primary contributing factor, but other factors include pollutants and chronic respiratory disorders such as asbestos working in construction or insulation or manufacturing. Common symptoms are dyspnea, shortness of breath, wheezing, production of thick mucus, restlessness, fatigue, anorexia, persistent cough, and peripheral cyanosis, such as clubbing of the fingernails. Obstructive sleep apnea. Relaxation of the posterior pharynx muscles during sleep causes the trachea to narrow and close and momentarily stops the breathing of the patient. It interrupts sleep, causing fatigue. Risk factors are being overweight, having enlarged adenoids or tonsils, male, gender, alcohol, and sedative uses. People are more prone if they have hypertension, heart disease, memory problems, headaches, and depression. This is commonly diagnosed by having a polysomnograph performed. Continuous positive airway pressure machines. We often call these in the clinic CPAP machines, CPAP, abbreviation for positive airway, continuous positive airway pressure. As you can see, this patient is hooked up to a CPAP machine while he is Sleeping, this helps keep the airways open and keeps the air flowing. Lung cancer, 90% of lung tumors are linked to cigarette smoking. The lung is the most common site for secondary tumors from metastasis of other tumors. The early symptoms include chronic cough, shortness of breath, and chest tightness. Some other symptoms that are more longer term are atelectasis and hemoptysis. Unless it is diagnosed very early, the prognosis is poor even with surgery, radiation, and chemotherapy. Carcinoma of the larynx, linked to smoking and chronic alcohol consumption. 90% of cases of laryngeal cancer occur in men. Hoarseness, loss of voice, and dysphagia are common symptoms. Surgical treatment consists of partial or total laryngectomies. When assisting an examination of a patient with respiratory problems, it is important to have the patient disrobe from the waist up and put a gown on. It is important to assist the physician, provide privacy and support of the patient, and perform diagnostic tests as ordered. Most of these patients should be sitting in a high Fowler's position. This is usually the most comfortable for them to be breathing. Diagnostic procedures for tuberculosis. We administer the Mantoux test. An intradermal injection of PPD is given. Positive Mantoux reactions indicates a latent or active TB. If they do have a positive test, a patient will have to undergo a confirmatory chest x-ray. If the chest x-ray is negative, then the patient can wait 4 to 5 years to have this repeated depending on the healthcare facility and where you work. PPD tests or Mantoux tests, if you have had a Mantoux test within a year and that year has not lapsed, you can have a one-step test. If that year has lapsed, you will need a two-step test, and the second test needs to be 1 to 3 weeks after the first. After administration of the PPD, the patient will have to wait 48 to 72 hours before the test is read. Spirometry. Here is a picture of a spirometry machine. Spirometry can also be called a pulmonary function test. Spirometry procedure. The chin should be slightly elevated and the neck slightly extended. Take a deep breath. Take as deep a breath as possible. Blow the air out hard and do not stop blowing until you are told to stop. Some of the things that the pulmonary function test evaluates. The pulmonary function evaluates 8 different things. The first one I'm going to talk about is the tidal volume. The tidal volume gives us the volume of air expired and inspired during normal respiration. The patient instructions for this test during the pulmonary function test is the patient breathes in and out normally with lips pursed around the mouthpiece. The vital capacity is the maximum amount of air that can be expired after maximum inspiration. The patient instructions for this portion of the test are the patient takes a deep breath and exhales completely, but not forcefully. Inspiratory capacity is the maximum amount of air that can be inspired after a normal expiration. The instructions for this portion of the test is the patient breathes in and out normally, then forcibly inhales at the end of the tidal volume. The next portion is the expiratory reserve volume, which is the maximum volume of air that can be exhaled after a normal expiration. Patient instructions during this portion of the test are patient breathes in and out normally, then exhales forcibly at the end of the tidal volume. Residual volume is the volume of air left in the lungs after forced expiration. The patient does not need to do anything for this portion of the test. This is something that our machine records. Functional residual volume is the amount of air left in the lungs after a normal expiration. So this is actually a calculation that we do, which is the expiratory reserve volume plus the residual volume. There are no special instructions that we give the patient in doing this portion of the test. Forced vital capacity is the amount of air that can be forcefully exhaled from a maximum inhalation. We will instruct patients to inhale as deeply as possible, then forcibly exhale as much as possible. And the last one is maximatory volume ventilation, which is a maximum volume the patient can breathe in and out in 1 minute. The patient breathes in and out as deeply and as frequently as possible for 15 seconds. And then that total volume is multiplied by the medical assistant by 4. Test results. After we get all those results and do all of our calculations for the pulmonary function tests or the spirometry, we place the results of the maneuvers with the patient's medical record on the physician's desk. If results are less than 60% of the predicted value, the patient may be given bronchodilators and be retested to determine the impact of the inhalant on the function. This often happens in our pulmonary departments where they will do a baseline and then they will administer medication to see the types of reaction, especially in asthma patients. And then we ask the patient to wait while the physician reviews the results. Pulse oximetry is a non-invasive method of evaluating the pulse rate and oxygen saturation of hemoglobin in arterial blood. It identifies the percentage of hemoglobin that is oxygenated in comparison to the total amount of hemoglobin available. Here is a picture of a pulse oximeter, and the 76 is a pulse, and as you can see here, the SpO2 is always in a percentage, it's always recorded as a percentage, is 98. And on the top we have the blood pressure, and on the bottom we have the temperature. It's important when doing pulse oximetry that patients remove nail polish. Sometimes the pulse oximeter does work with nail polish, however, for best results it is important to remove it. Obtaining sputum for culture. Requested when the signs and symptoms are accompanied by physical evidence of pneumonia, TB, and other infectious diseases of lower respiratory tract. Sample is cultured and incubated, and the pathogenic organism grown in the culture medium is identified. The sample may also be sent to the laboratory for cytological analysis. Methods of sputum collection. Expiration is most common. Instruct patients first thing in the morning to cough deeply and collect 1 teaspoon into the specimen cup. I generally don't like to give patients a quantity because that's what most patients will focus on. What I do instruct patients to do is cough deeply. We do not want a spit specimen. That is not what we want. That will be automatically rejected by the lab, and they will ask you to recollect. Return to the office or lab as soon as possible. Other methods that we can get a sputum collection are tracheal suctioning and bronchoscopy in the office. Bronchoscopy, you may schedule the test and instruct the patient to prepare and help answer questions. Provides an endoscopic view of the larynx, trachea, and bronchi. Physicians use a fiber optic instrument to view and collect tissue samples. Patients should not eat, drink 4 to 8 hours prior to and perform good mouth care prior to and after. Patient is sedated and a topical anesthetic is usually used so the procedure is not uncomfortable. All patients should have a driver for these procedures. Patient education, you play a vital role in allaying patients' fears by explaining what the test is, making sure the patient understands how to prepare for the exam and what will be expected during the exam. It's important to give handouts and brochures, especially with pictures, that kind of alleviates the fears of what is going to take place during those procedures. Legal and ethical issues, make sure a written consent form is obtained from the patient and is in the patient's medical record for any invasive tests. Any type, like a bronchoscope, is very common to have a consent. Obtain a consent form for any referral to a specialist in order to send the medical records to the consulting physician. So if you are working in primary care, you would fill out that referral to send them to the pulmonary medicine doctor. Physicians must write orders for the amount of oxygen therapy. So all oxygen has to have a written order in order for it to be administered, whether it is in a outpatient setting, inpatient setting, and in an emergency type setting, we would take a verbal order but then look for a written order later on. And for a respiratory practitioner to follow up on the patient's home care.